It's been nearly 80 days since COVID-19 came to New Mexico. Let's take a look and see how we're doing. We'll start with a little warning. Data from public sources can vary. For example, something I present may be from a few days ago or a week ago, and something may be from more recent publications. This is a graph of cases, new cases per day, normalized by population. What that means is that we take the total number of cases and we divide it by the population. We'll look a little more closely at New Mexico's numbers in a minute, but here I wanted to show you New Mexico compared to other states. We are certainly not the highest, but you'll notice we are not that far from the highest, being New York and Louisiana. Conversely, if you take a look at Alaska and Hawaii, they have managed to pull their daily case rate down substantially. Also, look at the early part of the graph. You'll see that all states started out with an exponential rise. New York and Louisiana had it particularly bad because they had very specific outbreaks. But all states started flattening out as public health protection orders, restrictions in activity took place. Let's look now at our total trends. The red dotted line represents the exponential rise of cases that occurred prior to the public health protection orders. The blue line represents total number of cases to date, and the red line represents deaths to date. Again, notice this is a logarithmic scale, which allows us to see changes in low numbers as well as high numbers. We are currently over 7,000 cases in New Mexico, about 80 days in, and we have about 335 deaths. As we'll see later when I talk about the 2-week offset case fatality rate, deaths are offset by about 2 weeks, but let's look at it denominated by population. So here's a graph that shows the number of total cases per 1 million people. Let's see how this compares to other states. So when we look at confirmed cases by population, you can see that we are considerably below New York and Louisiana, but there are plenty of other states that are lower than we are. Where within New Mexico are these cases occurring? Well, if we look at raw numbers, they are occurring mostly in the Northwest, San Juan, McKinley, and quite a few cases in Bernalillo as well. However, when we denominate that by the population, we see that Bernalillo does not have a particularly high case per 100,000 rate. That's simply because there are a lot of cases, but we have a large population. When looked at a population level, McKinley stands out as the county with the most number of cases per population. By the way, it's important to note that this is cases per 100,000 population. That is the way we should be talking about it. You will occasionally read this as prevalence rate, but as I will explain shortly, that's not the correct term. So how fast are our cases growing? From a peak a couple of weeks ago of about 166 per day, we are now down to 127 new cases per day. One interesting way of looking at the information is to calculate the percentage of tests that are positive. That rate has actually come down a little bit. And why has that rate come down? Well, most likely it's because we are increasingly testing non-symptomatic people or people with minor symptoms. Remember, when we first started testing, only people with symptoms were tested, so they were much more likely to have the disease. Increasingly, we are testing people who are either concerned or who are workers. For any number of reasons, we may be testing more people and finding that the presence of the disease in a wider population is hopefully less than in our early testing results. The total number of cases per day varies by region. The dotted line shows New Mexico overall, pretty much what I've just been showing you. But as you can see by the colored lines, the big bump that occurred is mostly due to the Northwest, and the metro area has waxed and waned. The Northeast area has stayed pretty constant. The concern right now is the Southwest area, which appears to be taking a little bit of a rise. So this is a good question. Are things getting better? One way of looking at it is to look at doubling time. I will point out this is not an official calculation. Notice at the very beginning, it took well less than a week for cases to double. But every week, more or less, it's taking longer and longer for the total number of cases to double. When the state asks the question, are things getting better, it uses what is called gating criteria. These are essentially threshold levels. When the threshold is crossed, meaning things are better, the state uses that to determine if it can loosen the restrictions, primarily on business closures. I'm not going to talk about testing capacity and contact tracing in this video, as it won't help you understand things very much, but I will talk about the other two measures. The first is the measure for the spread of COVID-19. The state uses a measurement called the effective reproduction rate or ratio. This number is a complex calculation. It also depends on a number of assumptions. You will find different estimates for this R value depending on who's doing the calculation. Any given R value may be fraught with errors of assumption. However, if the R value is measured the same way each week, then the trend of R value may be useful to show that people are spreading the virus less and less. The R value essentially means the number of people that an infected person goes on to infect. So if an infected person infects 2 more people on average, that will give the effective R value of 2. If the R value drops below 1, then eventually the infection dies out. The gating criteria is a balance between practicality and the ideal of getting the R value less than 1. The gating value at this point is 1.15 or less. Now let's look and see what's going on. So we said that the actual goal, the ideal goal, would be an R effective less than 1. That is simply not likely to happen, perhaps ever, but certainly not for some time. The gating goal is 1.15. The Department of Health divides public health regions as shown. As you can see, all regions except the Southwest are either below or very close to the gating criteria. As I said, while there are many arguments about the effective R number, if it is measured the same way each time, the trend may be instructive. The dotted green line shows the gating criteria, the threshold, and lower is better. Most of the public health areas are getting close to the threshold or have surpassed it. None, of course, have dropped below 1, which would be ideal. The next gating measure I want to talk about has to do with healthcare resources. The state measures this in large part by looking at the capacity of its hub hospitals. If you look in the upper right, you'll see which hospitals are considered hub hospitals. The light green dotted line is considered the baseline capacity. This was the capacity of hospitals prior to COVID-19. The dark blue line shows the number of occupied beds relative to that baseline capacity. Under ordinary circumstances, this would mean that the capacity of the healthcare system is being exceeded. However, the hospitals have increased their maximum capacity to the dotted red line at the top. From the perspective solely of bed capacity, then the occupied beds are well below the concerning level of maximum capacity. This says nothing about the capacity of human beings who have to care for patients, doctors, nurses, respiratory therapists, all of whom are working at maximum capacity. The solid red line is something called the Crisis Standards of Care threshold. If the number of beds occupied goes above that level, then certain changes would happen. I have no idea what those changes are. That is not published anywhere. This graph represents the total number of hospitalizations. So you can see it grew fairly rapidly and may be starting to level off. The experience of hospitals, however, varies by the region they're in as well as their size. Let's look at one example. This graph is from a large hospital. Please note that I did not misspell the word ventilated. This came from the hospital. In blue, you see the number of COVID patients who are ventilated on a ventilator, a breathing machine, and in orange, the number who are admitted to the hospital but not ventilated. The gray represents suspected COVID cases. So for this large hospital, at this time, of all the COVID cases, 60% of them are on a ventilator. Conversely, in a small hospital such as this one, while there was initially a high percentage of COVID patients on the ventilator due to the location of this hospital, that has trailed off, and now the number of patients on a ventilator has dropped. COVID-19 affects all age groups. The highest number of people that are being infected are somewhere in the 20 to 70 group, but remember these are also the people most likely to have been tested because they were mobile and they could get to a testing center. There is something in this data, however, that is very disturbing. If you look at the age distribution, look at 0 to 9 and 10 to 19, combined that's 13%. So children are being infected with COVID-19. Men and women are being infected at roughly the same rate. These differences are not important. Compared to their relative population, Native Americans are highly overrepresented as cases of COVID-19. Men and women die from COVID-19 at about the same rate. Again, this is not statistically significant. This, however, is quite significant. Almost everyone, 90% of people who die from COVID-19 have underlying medical problems, either directly or that cause them to be in a long-term care environment. Nearly 40% of deaths occurred in a long-term care environment, which can include congregate living, not necessarily nursing homes. Now let's talk about death rates. The problem with death rates is there are so many of them, and they can be exceedingly confusing, not only to you, but to those of us who think we know what we're talking about. So let's try to put these different types of rates in perspective. And the first thing we want to understand is what the word case means. So a case specifically means someone who is tested positive for active COVID-19 virus called the SARS-CoV-2 virus. It doesn't mean people who are infected because we don't know everyone who's infected. It means the people who tested positive. If you look at cases, there's 3 conditions a person can be in. They can have died, they can have recovered, and we would call those people resolved. We know that after time they've either recovered or they have died. And then there is a whole group of people we don't know what their outcome will be, either because they've just been diagnosed and it can take 2 weeks or more for a recovery or a death, or they are lost to follow-up. They got tested positive, they were seen, they went home, they recovered fine, nobody knows what happened to them. As I said, it is important not to confuse cases with infections. We wish we knew infections, but there are two groups where we won't know if they're infected. First, someone may get tested and the test is negative, even though they are infected. We call that false negatives. And then there are people who are infected but were never tested. We know that perhaps 44% or more of people who have COVID-19 have no symptoms. They may never go in to get tested. Many will have mild symptoms. They may decide not to go in to get tested. There are people who, for any number of reasons, including legal ones, logistic ones, cultural ones, will not go and get tested even though they're infected. Infections is what we want to know. Infections is what we don't know. Then, of course, it leaves the ones in the bottom. These are people who are not infected. With these definitions in mind, we can now describe the different rates. The first rate we want to talk about is prevalence. This is how much disease is there in the population. We calculate that by looking at the number of infections and dividing it by the Oh, wait a minute, I just remembered. I said we don't know the infections because we don't. So it'd be better to call this cases per 100,000. You will see the word prevalence, but really the correct term is cases per 100,000. Mortality rate is fairly simple. It's the number of people that have died divided by the entire population. This is something epidemiologists like to do, and it's very useful for chronic diseases where you can compare year to year, for example, how many people die of heart disease and cancer. For a rapidly shifting situation such as COVID-19, it's not as helpful, and for you, it really isn't helpful at all. So we're going to cross that one off the list. Survival rate is fairly simple. This is how many people that have resolved their case is over, they are theoretically over COVID-19, and they are alive. And now we come to the big one, the case fatality rate. This is the rate you will hear about the most. It is the number of dead divided by the number of cases. So take a look again at that diagram, the number of dead over number of cases. The infection fatality rate is actually what we want to know. After all, what matters is if you get infected, what's the chance you will end up dead? That's what most of us are concerned about. This is the rate that we all wish we knew. However, we don't. Why? Because we don't know the number of infections. Why? Because we don't know the number of false negatives, and we don't know who's been infected but not tested. So we're kind of left with these rates. The case fatality rate, which is the number of dead over the number of total cases, and the survival rate. So let's look at New Mexico's case fatality rate. It is leveling off at about 4.5%. By comparison, we can look at the national average, which is about 5.6%, or seasonal flu, which is 0.1%. It's important to know about flu, however, there is an extensive system throughout the country for measuring cases of flu, both in the outpatient world and in hospitals. So it's much easier to know what's really going on with flu than with COVID-19. Hopefully, as we find more and more cases that do not lead to serious disease or death, the case fatality rate for COVID-19 would drop as well. Bear in mind this is an overall number. When we look at specific ages, we see that the case fatality ratio varies a great deal by age. We define the age-specific case fatality ratio as the deaths in the age group divided by the positive tests in that age group. This shows that the risk of dying increases with age. Now, if we look at total number of deaths, these are not rates, but total number of deaths, we see most deaths in New Mexico have occurred in that 50 to 99 group, particularly in the 80 to 89 group. However, a couple of things to note. First, there are people in their 20s, 30s, and 40s who are dying. A common misconception is that the older people who are dying were going to die anyway. These are not just people who are at death's door in a nursing home. These include many active community elders who would have had another decade of life. The drawback to the case fatality rate is that it counts today's deaths by today's cases. But as we've seen, deaths can take 2 weeks to occur. So one thing we can do is ask the question of how many deaths are there today compared to how many cases there were 2 weeks ago. This is not an officially sanctioned measure, but I find it useful. And the 2-week offset case fatality rate has dropped to about 4.9%. Recovery rate is fairly simple. Number of people who've recovered divided by the number of people that have had the disease, and that number is running about 89%, roughly 90%. So 90% recover, 10% die. However, the number of recovered is likely to be highly undercounted. After all, as I said, many people may just get over the disease, never go see anybody, may sit at home, and nobody's counting this. So it is very possible over the next months and years, we learn that this recovery rate is much, much higher. Well, that wraps up this presentation. So where do we go from here? Well, stay tuned. I'm going to do more videos that explain how to read and understand graphs you may be seeing about COVID-19 and how to discard the ones that are just nonsense. I'll try to give you some more insights into the pitfalls of rates that are being reported and perhaps give you a better understanding of terms like R and herd immunity. You want to keep track of the changes in the public health orders that come from the Department of Health and the governor. I'll put in the description links to how to see those changes at cv.nmhealth.org and go to the newsroom section. Also, Governor Lujan Grisham gives a weekly press conference. I will give you a link to how to get to that. That's worth seeing if you want to get the news before you see it on your local news. Lastly, as always, if you are concerned you or someone in your family may have COVID-19, call the COVID-19 hotline. Thank you, and I'll see you next time.